think it's time to do the introduction. So welcome everyone to this Thursday webinar with Dr. Tom Bayne on healing the leaky gut, or another word, maybe microbiome restoration or microbiome balance. Or but yeah, we have many experts with us today. It's been a very, very popular sign up for this webinar. So this is really something people are interested in. So I'm Anne-Catherine, co-founder of Nordic Laboratories and DNA Life, a group of companies that is dedicated to change healthcare through functional medicine, lab testing, supplements, lifestyle changes, etc. So I'm just going to say in regards to the recording and slides, etc. from last week on TrueCheck, we have decided to share that one with everyone. And if you haven't had it yet, I think it's because we're still just working on a few technical things, and it will come out probably today or tomorrow. And then our next webinar is Thursday, the 17th of February. It's on nucleotides, so again on a supplement with Peter Köppel, who's going to introduce us and teach us a few things about nucleotides. So the recording and the slides from today will also be shared with you as soon as possible. And the supplements that are mentioned today, of course, you can find in your practitioner profile, and we will share the link out with everyone after this webinar today. So the star of the show today is Dr. Tom Bayne. He's been here before. He was here in the summer, so about half a year ago, and it was a very popular presentation. He learned or taught us a bit about probiotics as supplements, and today he's gonna dive more into how we create balance in the gut. So with that, I will pass on the stage to you, and you can take over the screen, and I'll mute myself just before I completely hang up. Remember, ask in the text. I will put down the questions that I can't answer myself, and we will do a Q&A at the end. So thank you. And Tom Bayne, welcome for today's webinar.
Thank you, Anne-Catherine. It's a pleasure being here. I appreciate you guys taking the time to come listen to me talk here. We're going to have a really interesting conversation here. So I'm going to be presenting some information around the science of leaky gut and some of the science around how to heal the leaky gut. And so I'm going to kind of push through the research part. You know, you guys can look at the slides, you can go deep into the different studies. I'm just going to kind of hit the high points of the studies and kind of give you some background as to, you know, why we are utilizing some of the ingredients that we're using in the process of restoring a healthy microbiome and a healthy gut. And so I'm going to go through it pretty quick so that I can save time for the end, because I enjoy more of the conversational thing. I want you guys to ask questions. I want you to feel comfortable with this information and being able to ask specific questions about patients or whatever may be on your mind. So thank you again for coming, and I hope you enjoy the lecture. So when we talk about the microbiome, you know, we look at the science of the microbiome, you know, through the 70s, 80s, 90s, early 2000s. You know, there was this idea that we might have, you know, maybe we've got 15, 20, 30 different types of bacteria that live in our microbiome. You know, it was with the Human Microbiome Project that we actually found that there are actually 1,000 different beneficial species in the human microbiome out of 35,000 possible species. And so really what we have is the microbiome. A healthy microbiome is like a vast ecosystem, like a jungle, right? And if you look at the science, or I won't say the science, if you look at how many of us, myself included, you know, I've been practicing for 25 years. So the things that I've prescribed to patients in the past, different products, were products that were around this idea of seeding the microbiome. We're going to sprinkle these bacteria in there, and these bacteria are going to colonize and they're going to grow and they're going to crowd out the bad guys. Well, take a look at this picture, right? This was not done by seeding, right? This is nature. This is the environment dictated what plants grew where and how, and health of the jungle is described as diversity, lots of diversity. And so that's the same thing with the microbiome. Now, many of the people that you'll see, many of the patients that come into your offices, their microbiomes, instead of looking like a jungle, look more like a desert. There's a lack of diversity. There's a lack of health. And so that's what we're going to be talking about today. And that's what we're going to be focused on, the science around diversity, the microbiome, and healing the leaky gut. So if you look at the schematic on your left, right, this is going to come back into play, but this is the healthy gut schematic here, right? So this little caterpillar-like creature that you see, the purple, green, and blue winding, that's your epithelial layer. That's the single cell barrier that separates your body from the environment. And so if we look above I call it a caterpillar, but it's your epithelial lining. So if you look above it, we see this blue wave, this thick blue wave above the epithelial layer. So that is the mucin layer, right? So the mucin layer buffers the microbiome, which you see above the and all that, but it's buffered away from the epithelial layer. And then below the epithelial layer, you'll see that's the basolateral circulation. That's where we're absorbing nutrition, we're absorbing things into our body. And so this drawing to the left is a healthy microbiome. We see increased microbial diversity. We see low levels of pathogens and toxins. We've got this thick mucosal barrier, which we're going to spend some time talking about. We've got strong epithelial tight junctions. There's no holes between the different epithelial cells. And there's low mucosal inflammation. Now, this is the schematic on the left now is the leaky gut. So what you see is that how this process started was that the microbiome above the mucin layer became dysbiotic. And then the bacteria started to degrade or eat away at the mucin layer. And eventually it ate the mucin layer away to where the microbiome was now laying or making contact with the epithelial surface. Your epithelial cells don't have the ability to say, oh, these are healthy bacteria and these are unhealthy bacteria. They just see bacteria, right? And so they respond with an inflammatory reaction. And so what we see in this leaky gut schematic here is we see that the blue mucin layer has been degraded. The microbiome has touched the epithelial surface. We see spacing between the epithelial cells, and we see leaking of LPS, lipopolysaccharides, the outer membrane of dead bacterial cells. We see that seeping in to the bloodstream. We see a macrophage grabbing onto the LPS, recognizing it and saying, oh my gosh, there's a septicemia is happening here. And it responds by producing interleukin-6, tumor necrosis factor alpha, interleukin-1 beta, and a host of other cytokines. It creates an inflammatory process that is the end result of the meal that was just eaten. And so things that can damage the epithelial layer, the mucosal layer, are things like antibiotics, excessive alcohol. Excessive alcohol in the sense of really dehydration is the thing about excessive alcohol when it comes to the leaky gut that's really bad is the dehydration component. Really, alcohol really eats up that mucin layer. But smoking, stress, lack of sleep, and overly intense exercise, we've got, if you've ever had the opportunity to train like marathon runners or even ultra marathon runners, a lot of those athletes develop runner's gut. They develop an almost inflammatory colitis in response to their intense exercise. And so that's really just an excessive leaky gut situation in those athletes. Artificial sweeteners, saturated fats, and glyphosate are some other things that play a role in damaging our epithelial layer and creating the leaky gut. So here's the picture side by side. And so the question for all of us, if you're a practicing physician or practitioner, if you're seeing patients, the question that you will ask yourself, should be asking yourself with every patient is, how do I take this person from where they are on the right when they came in, and how do I get them over to the left where they need to be? Right. And that's what we're going to be talking about today. We're going to be talking about how to reduce the inflammation, how to restore the balance in the epithelial layer, and how to balance out the microbiome to create that healthy gut. So let's talk about that process in the order that it happens, right? So the first thing that goes out of balance is a disruption of the gut microbiota. And so here's some research that shows that disruption of the gut microbiota has been implicated in a number of diseases: obesity, inflammatory bowel disease, irritable bowel syndrome, type 2 diabetes, colorectal cancer. And so that's just in this study. I'm going to bring other studies into that. We're going to talk about anxiety and depression and on and on. So the research that supports the notion that a disruption of the gut microbiota leads to dysfunction and eventually disease is overwhelming. If you need more data on that, just let Anne-Catherine know, and I'll be happy to give you a download of all the research that we have that supports this notion. So what we want to look into, we want to understand is, how do we intelligently modulate the intestinal community? How do we change it from this? How do we take this environment of 100 trillion cells, and how do we restore balance, right? How do we make it so that the good guys are in charge? And one of the things too that we get caught up in is this notion, I even just said it myself, is good and bad, right? And so what we found in the last decade is that there's really not a lot of bad bacteria. What's bad about them is that they're overgrown. That there are too much of them. H. pylori is a great example. H. pylori, when it is in modest numbers, it's actually very beneficial to help with satiation, the feeling of being full. And but when it's overgrown, it's implicated in the development of ulcers and gastrointestinal dysfunction. And so where, in my training, when I first, it's like, oh, if somebody shows up with H. pylori, kill the H. pylori, got to get rid of it. Now we see that's not the way to do it. We have to intelligently modulate the microbiome. We don't want H. pylori and E. coli to go away. But we want them to take their position in the microbiome, their low number position where they're not promoting inflammation and creating dysfunction in the microbiome. So this is a particular study that was associated with inflammatory bowel disease. Being a gut-centric practitioner and always having been focused on the gut, the inflammatory bowel patient is kind of the biggest teacher for me, I would say, are the inflammatory bowel patients. They really don't respond the same. You kind of really have to be individualized with these people. And so I feel like my training and my understanding of how to treat people has really come from the large percentage of patients that I've dealt with that have inflammatory bowel disease. And so this study itself shows that the most consistent observation that's seen in inflammatory bowel disease across the board is reduced bacterial diversity, reduction in firmicutes, and an increase in proteobacteria specifically. That imbalance in those bacteria is the telltale sign, or the common thing that researchers are able to see in all inflammatory bowel disease patients, right? So they weren't able to say that they all had an overgrowth of E. coli. Some of them did, but they were able to say the most consistent observation across the board is a reduction of diversity. And like when we started out this conversation, that's ultimately what it's all about when it comes to microbiome. How do you restore diversity? Diversity equals health. So I want to talk specifically about Keystone strain bacteria. So, when we look at the probiotics that are in the marketplace, so the number one prescribed probiotic worldwide is Lactobacillus acidophilus. Lactobacilli make up about 1% of the microbiome, right? So when we supplement Lactobacillus bacteria, if in fact they did get into the microbiome, crowd out other bacteria and colonize the microbiome, if they actually did do that, we would actually be causing redundancy in the microbiome. We would actually be reducing diversity. And so we've come to learn that Lactobacillus acidophilus doesn't really colonize in the gut. It has lots of benefits, has lots of anti-inflammatory benefits, but it's more of a cell signaling molecule. Your Lactobacillus and bifidobacteria, they have benefits, but they're more cell signaling bacteria. They don't change the microbiome. They don't increase the growth of Keystone strains. So the Keystone strains are strains of bacteria that are almost always anaerobic bacteria, and they are high short chain fatty acid producers, right? And one of the kings is Akkermansia mucinophilia. So it's been inversely associated with obesity, diabetes, cardiometabolic disease, inflammation. And so it is a anaerobic bacteria that produces very high concentrations of short chain fatty acids. And so the research shows that in order to improve these metabolic disorders, obesity, diabetes, liver diseases, that an increase in Akkermansia is critical in order to reverse and start reducing the inflammation associated with these diseases. And so you don't have a probiotic supplement that has Akkermansia mucinophilia in it. It's to date, we haven't been able to create an anaerobic bacteria that we can supplement. And so, so we have to find other ways to increase Akkermansia. And so that's what we'll be talking about today. Fecal bacterium prosnitzi is also, king of the microbiome is probably not the best term, because there's lots of kings, like there's lots of important Keystone strains here, but fecal bacterium prosnitzi is hugely important, and one of the Keystone strains very much associated with inflammatory bowel disease. And so what happens is when pathogens start to overtake the microbiome, pathogens like an alkaline environment, they don't like these acids, these short chain fatty acids being produced. So they create an attack plan against these anaerobes that are producing the short chain fatty acids. So when we look at stool test microbiome analysis of patients that are chronically ill, we see almost none of these bacteria, these Keystone strains. And so it's important for us to find a way to increase the concentrations of these bacteria in order to reduce the inflammation and to create balance and diversity in the microbiome. But in our minds, we're like, well, how do we do that? We take the bacteria. We can't do that with these anaerobes, so we've got to find other ways to increase them. So dysfunction of the mucosal barrier is the next step that happens in the process of the leaky gut. And so let's look at some of the research associated with that. So this study here shows that the epithelial barrier dysfunction is involved in inflammatory bowel disease, autoimmune disease, and systemic infection. And so if you go, we'll come back to that schematic that I had before, but if you remember, we were talking about the LPS that's making its way through the epithelial lining and getting into the basolateral circulation where the macrophage grabs onto it and then signals the inflammation, right? So in that process, the LPS, the lipopolysaccharide, is the trigger for the immune system. The immune system goes into that process where it thinks, oh my God, we've got septicemia here. And it goes into a process to start reversing or responding to that septicemia. That process has been implicated in almost every autoimmune disease that we know of. It's been implicated in every digestive disorder that we know of. It's associated with diabetes. It is the number one factor associated with someone going from hyperglycemia to diabetes. The number one factor is an elevated levels of LPS in their basolateral circulation. So this is ground zero for everything that you're doing, right? The researchers are focusing on lupus or rheumatoid arthritis, and it doesn't matter. The thing is it started with the leaky gut. The individual's genetics, their history, their traumas dictate how that inflammation is going to express itself. But the same problem you see with all of the people, practically everybody that walks in the door asking for help has this at the root of their issue. And so addressing this is critical if you're going to have success with your patients. So here's a really cool study, right? So the gut-brain barrier in depression, in major depression disorder. So the results of this study showed that intestinal mucosal dysfunction, characterized by a translocation of gram-negative bacteria, leaky gut, plays a role in the inflammatory pathophysiology of depression, right? So now we're back to that gut-brain thing again that everybody's talking about. Well, where does the dysfunction start when it comes to the gut-brain? Well, it starts with the dysbiosis that erodes the mucin layer, creates the leaky gut, spills the LPS into the bloodstream. And then depending on the individual, in one person it expresses itself as lupus, and the next person it expresses itself as depression. And so it's fascinating. And, I always try to push back when somebody tries to tell me that one thing causes everything. And so I get that, and I'm happy to answer all those questions, but the research is overwhelming that the translocation of LPS is at the root of many of the chronic inflammatory conditions that we see every day in our practices. This is a study that showed that acid reflux, GERD, that actually is a response to chronic mucosal inflammation. And most of that chronic mucosal inflammation is happening much lower in the intestines, but then triggers the inflammation and the reaction that expresses itself as gastroesophageal reflux disease. So just another research study showing that this mucosal inflammation is at the root of a lot of these different disorders. And here's a mucosal immune dysfunction in AIDS pathogenesis. And so in my training in Chicago, I actually worked in an AIDS clinic in the early 90s. And I frequently, when I go through these articles, I think to myself, man, if I had this information in the early 90s, how many people we could have helped, and so it's tough, we're in a much better place. But again, now with the HIV patient and the AIDS patients, we're able to study them and we're able to understand the pathophysiology much better than we were able to in the 90s. And so early HIV infection is consistently associated with rapid, dramatic, and largely irreversible depletion of CD4 memory T cells. And so, but the underlying issue in all of the patients is severe mucosal immune dysfunction. And the more severe it is, it's associated with the progression of AIDS. So what we thought was, well, you've got a high viral load count. And the higher your viral load count, that's what's going to help you. That's what's going to cause you to progress from HIV positive to full-blown AIDS. And so actually what we know now is that the viral load has nothing to do with it. The endotoxicity load has everything to do with it. So if you have a low viral load, but high levels of LPS in your bloodstream, you're going to age, you're progressing, your condition is worsening and it's progressing to full-blown AIDS. If you've got a high viral load, but no or low LPS in the bloodstream, then that's a patient who can live with HIV for forever, as long as they can maintain that. So in order to get that to that, the progression of the condition, there has to be significant mucosal immune dysfunction for that disease to progress. So let's talk about total gut restoration. Let's talk about taking that leaky gut and restoring it to a healthy gut. Taking this picture on the right and changing it to the picture on the left. How do we balance that mucin layer and get it so that it buffers the microbiome away from the epithelial surface, right? I've been studying the gut for a long time. I believe one of the things that is so just breezed over is the mucin layer. If you have a healthy mucin layer, those bacteria can't create the dysfunction of the leaky gut. And so having that mucin layer is hugely important. And I have to commend Nestle for bringing it to our attention, because they're the ones that have been driving that research. They've done some really cool stuff, and we'll talk about those studies coming up. But how do we restore that mucin layer? How do we balance the microbiome so that it's not dysbiotic and not degrading the mucin layer and creating the inflammation? So let's talk that through. So many diseases associated with low microbial diversity in the gut. So we want to revitalize that garden, right? So in the analogy that we use, instead of going into the forest and throwing seeds on the ground and trying to reseed the forest, what we're going to do is we're going to send in the gardener. And the gardener is going to remove the weeds, going to till the soil, going to put some fertilizer down. Okay. This is what spores do. Spores are the gardener of your microbiome. They modulate the microbiota through quorum sensing. Quorum sensing is how bacteria talk to each other. Spores are able to say not only when there are pathogens present, but they're also able to look at our own bacteria and say, wait a minute, these are beneficial bacteria, but they're in too high a concentration. I need to beat this down. We see this a lot in small intestine bacterial overgrowth, where it's good bacteria in the wrong place. Spores do a very good job of competing and reducing both pathogenic and beneficial bacteria when they're out of balance. And so quorum sensing is how they communicate with each other and how they communicate with the other bacteria in the microbiome. So we've been able to show in research that spores can increase short chain fatty acid production by 40%. And that's in 6 weeks. And so, and that in the studies, it was with no change in diet and lifestyle. Obviously, we're making diet and lifestyle recommendations with all of our patients. So that number we should be able to boost that number even beyond that 40%. But I've never seen a research study that shows any probiotic can increase short chain fatty acids by 40% in 6 weeks. So by increasing the short chain fatty acids, competitively excluding the pathogens, we actually start to increase or encourage the growth of keystone bacteria like Akkermansia muciniphila, Faecalibacterium prosnitzi, and Bifidobacterium species, particularly Bifidobacterium longum. And so spores recondition the gut by increasing microbial diversity and encouraging the growth of key health-promoting commensal gut bacteria. This is a huge portion of fixing the leaky gut. And for a long time, myself included, a lot of us thought all we really need to do is change the microbiome, restore health in the microbiome, and the leaky gut will fix itself. Sometimes that happens, but what we want to look at are the next steps. So HU58 is a single strain bacillus spore. It's been clinically proven to withstand high pH levels, temperatures, antibiotics, colonizes the gut. HU58 itself produces between 12 and 25 different antibiotics on its own. So what it does is it goes in, it uses the quorum sensing, it's talking to the bacterial environment, says, hey, wait a minute, here's a pathogen. So first, what it does, it tries to compete for space with it. Then it tries to compete for food with it. If that doesn't work, it turns on it, starts producing specific antibiotics towards that bacteria to kill it down. These aren't broad spectrum antibiotics. These are very specific targeted antibiotics. It's very useful in treating people who have gut infections, when you're looking to support immune function, and also in supporting immune health. So we did a study with liver failure patients, and we were able to show a dramatic reduction in ammonia levels. And what we were able to find later, working backwards, was that HU58 by itself, it competitively excluded the bacteria that were producing ammonia, but then it actually would engulf free ammonia in the microbiome. I might not get this right. Ammonium, when we take drugs for high levels of ammonia, what it does is it changes from ammonia to ammonium, and then that gives patients horrible diarrhea. And so, we're working with HU58 as an adjunct for liver failure patients to offset the problems of ammonia. So HU58 is the strongest of the spores that we've seen to date. It's the most potent competitive excluder of infection, and it's the most potent immune modulator. Restore Flora is a blend of two spores, Bacillus subtilis, the HU58 we just talked about, and Bacillus clausii. And it's blended with 5 billion of the Saccharomyces boulardii. We just changed that, so I was in my head going to say something else, but it's a 5 billion source of Saccharomyces boulardii. And so this is a very good formulation for helping patients who are on antibiotic therapy. This is a probiotic that needs to be taken before, during, and after antibiotic therapy. It's very good at treating foodborne illnesses, Candida E. coli, but both the Restore Flora and the HU58 are very good at balancing the microbiome and eliminating the dysbiosis within the microbiome. So now the next step in restoring the gut is to reinforce what we did in the first step. So what we've been able to see is that with the use of the spores, we see changes in the microbiome, and we start to see the Keystone bacteria come back, but we don't see them come back in significant enough numbers that they can take over, that they can, establish themselves as one of the main bacteria in the microbiome. And so what we figured was we needed something else. We needed some type of fertilizer that we could give those bacteria to increase their numbers. And that's what MegaPre is. MegaPre is a blend of precision prebiotics. Okay. So again, being the old guy here, having 25 years of practice, prebiotics are not a new thing to me. I've known about prebiotics, but the first generation of prebiotics were indiscriminate. They fed whatever was there. And so what you would see with early FOS, inulin, what you'd see is 2-3 people do really well with it. And then the next 5 people would come in bloated like they were 6 months pregnant. And so the reason was because the pathogens that were in their small intestine were eating that prebiotic, and they were benefiting from that prebiotic like the good bacteria was. Second generation prebiotics are precision prebiotics. They only feed the good guys. And so these prebiotics selectively feed Akkermansia, Mucinophilia, Faecalibacterium prosnitzi, and Bifidobacteria. And so this is the first precision prebiotic that we know of that's been clinically tested. It's got non-digestible oligosaccharides. Those are the different things that we use. We use 2 fructooligosaccharides from kiwi. We use a galactooligosaccharide from milk that's casein-free and lactose-free. And we use a xylo-oligosaccharide from corn. So one of the questions are a lot of the times when I'm doing this conversation, I'm just going to beat either the punch, but People are like, well, what about my patients that are corn sensitive? What about my patients that are dairy sensitive? A lot of people that have food allergies because their microbiome's out of balance, and they need restoration of the microbiome in order to not express the allergies. So when you talk about somebody who has sensitivities or acquired food allergies, what I have people do is I have them take small amounts of it. I have them wipe it on the outside of their mouth, close to their lips, and see if they get any kind of inflammatory reaction with that. If they don't, I start them at very small quantities of it. And more often than not, people with dairy and corn allergies respond favorably to the product because it's improving the health of their microbiome. And so I would caution you to be careful. If somebody's got an anaphylactic reaction to dairy, I would skip it. I wouldn't give it to them. We don't want to be silly. We don't want to throw out everything we know because we've got some new information. But at the same time, I think it's not as common to see anaphylaxis with foods as it is to see, an acquired allergy or a sensitivity. And so in those types of patients, I encourage docs to try it and see if it helps. But in order to fix those problems, we've got to balance out the microbiome and heal the leaky gut. So the prebiotics are very good at specifically treating or specifically feeding the keystone strains of the microbiome, the short chain fatty acid producing anaerobic bacteria. So here's some studies on it. So in this research study, what we saw with the fructooligosaccharides, we're able to increase Faecalibacterium prosnitzii by 100% in 4 weeks. They were able to increase the Akkermansia mucinophilia by 8,000% in 5 weeks. The GOS, the galactooligosaccharide, was able to increase bifidobacteria by 67% in 1 week. The xylooligosaccharide was also able to increase the bifido by 21% in 4 weeks. And so when we add the second step of total gut restoration, when we add the oligosaccharides, the prebiotics to the spores that have started the reconditioning process, we really create that strong foothold or footprint for these important bacteria so that they can establish themselves as the dominant bacteria in our microbiome. And this is critical in order to reduce inflammation and to correct the dysbiosis. So now we've got this much more beautiful environment, but we still haven't done anything to the mucosal layer, right? In some of your patients, you will have helped the mucosal layer at this point because the shift in the microbiota and the increase in the growth of the short chain fatty acid producers by itself will reduce inflammation, increase the growth of the mucosal layer, and you'll start to see improvement, right? So not every patient needs all three of these steps, right? So, but we're going to talk about it as if we're going through this 1, 2, 3 step process. It's up to you as a clinician to use your clinical expertise to see if they actually need it, right? A lot of times, step one is enough. A lot of times, step 1 and step 2 is enough. But sometimes you need step 1, 2, and 3. And so this is step 3. And so how do we rebuild that thick gel-like mucus layer that protects the intestinal lining from damage? And so we talked about all the chronic diseases that are associated with the breakdown of the mucosal barrier. So we know that butyrate increases the production of mucin, and it upregulates the genes that help us produce the mucin. And so Nestle's the one that did the research, and what they showed was that there was a specific blend of 4 amino acids that were able to increase the mucin layer by 97% in 4 weeks. Just basic amino acids, nothing of any real, they didn't develop something or create something out of nothing. These are just aminos that are just sitting around on the shelves. But in the percentages, the 4 themselves and in the percentages that they are, when they're given to, when they're supplemented, will increase the mucin layer by 97%. And so in the mega mucosa, we combine those 4 amino acids with bovine serum immunoglobulins. And so the bovine serum immunoglobulins, I like to think of IgG as intelligent charcoal, right? So when we take charcoal, what we're trying to do is we're trying to bind the toxins. We're trying to eliminate waste and toxins from our intestinal tract before they're absorbed into our bloodstream, right? And so IgG works the same way, but it focuses on reducing the LPS, reducing aldehydes, alcohols, and other toxins that are building up without leaching minerals and other things that charcoal does, right? So that's how I refer to it with my patients as an intelligent charcoal. It's reducing the load of waste and toxins in your microbiome, but it's not doing it by subtracting nutrition at the same time. So I have to say, I personally and professionally love working with the immunoglobulins. They have such a balancing effect on so many people. And, doing what I've done for so long, a lot of the people that seem to be attracted to me these days are those kind of canary in the coal mine kind of patients. Those patients who've been to every doctor in town, they can't take anything because they react to everything. And so when I get these patients, I start them just on standalone immunoglobulins. And I just feed it to them slowly like a food, just 1 cap at a time, 2 caps, 4 caps, 6 caps. And I get them up where I can get them taking up to 5 grams of the IgG a day. And once I do that, then I know I can start this whole process. Now I can give them the spores. I can start the prebiotics because we've reduced the inflammation enough to get them into that. So I've talked about this process in a 1, 2, 3 format, but again, I would ask you to use your clinical judgment to what order you may do that. You may feel that, hey, we need to reduce inflammation first before we start working on the microbiome, right? The reason we talk about it in a 1, 2, 3 process, because that's how we see it from a pathophysiological perspective. That's the way it goes. So can we go backwards and reverse? So that's how we put the program together. So this is the study that I referred to with Nestle. So the aminos are threonine, serine, proline, and cysteine. And so, I'm sorry, it was 95%. I said 97, so my bad. But yeah, so this was an incredible study, and they really did a good job because they tested it against a full blend of all the amino acids. They tested it against different combinations of different amino acids, and this was the one blend that did the most benefit. And so we take these 4, blend it with the bovine immunoglobulins, and we also have a polyphenol blend in the mucosal repair. And so the polyphenol blend is another thing to help balance the microbial diversity. The beneficial bacteria love those polyphenols, almost like a prebiotic. And we're learning more and more about the polyphenols and the impact that they have on the microbiome. We don't know everything yet, but we know enough to know that they balance the microbiome, reduce inflammation, and help with the process of healing up the leaky gut. Okay, so that's our process. I did want to throw this on at the end. It does come into play a lot with some patients. This is a new product that we formulated, and many, I would say 90% of the products that we have in our line are the result of feedback from practitioners like you guys. I'm having a challenge with this patient that's expressing these symptoms. How can you help me? When you look at 90% of our products, they've come from conversations with practitioners like you guys. And so this is one of our latest products called FODMate. And it's a very innovative enzyme formula. It's formulated to help digest FODMAP foods. And so, I mean, all of us that have worked with patients that are sensitive and put them on FODMAP diets, I would venture to say we've mostly failed in doing that because it's so difficult for a patient to follow that diet. I'm not going to say that I've not seen patients follow it. I have, and I've seen the benefits of it. But when we're talking about the masses and getting high concentrations of people to be able to follow that diet, it's very difficult. And the FODMAP product is kind of a way, not to say you don't have to follow a FODMAP diet, but more of saying, I'm going to support you with your FODMAP diet so that if you do happen to be exposed to some high FODMAP foods, these enzymes will break them down, digest them before they're able to create the inflammation and dysfunction that they create, which is typically, the constipation, cramping, gas, abdominal pain type presentation. So these are the ingredients that are in it. And so it's a lactase enzyme, and then a number of these other alpha galactosidase, endo and exo inulinase, glucose isomerase, and pectinase. So these are pretty exotic enzymes, but all enzymes that we've been able to do individual research with to see the impact that they have on FODMAP foods. And we've done some small scale studies, enough for us to launch the product, but we're in the process of doing larger scale studies to prove the fact that we are helping patients digest these FODMAP foods and reducing the bloating and gas that they exhibit. And again, we see this a lot with small intestine bacterial overgrowth. That's kind of a buzzword right now. A lot of people are over-diagnosing SIBO these days, but nonetheless, when we get into those situations and patients are expressing those types of symptoms, this is a fantastic formula. I encourage you to try it out, and patients love it. So it's a very effective product. So total gut restoration, we look at our spore-based probiotics, our prebiotics, and our mucosal repair. And so what I will do now is I will open things up for questions. I see a lot of them in the chat box. So, Anne Catherine, you want to lead this, or do you want me to just start firing?
Yeah, I'm the one who's leading. I'm the one who's leading.
Okay.
Exactly. So some of a question that came up, and now you already alluded a little bit to it by some of your patients being the canary in the coal mine, but of course the difficult patients, such as patients with mast cell activation syndrome and similar conditions on histamine and so on. Do you have experience with that?
Yes, unfortunately, yes. I mean, I say unfortunate for those people, and it is also, like I say, those patients are some of the greatest teachers that I've experienced in my clinical practice. But the problem with a lot of other probiotics is that they trigger histamine reactions. Spores do not trigger histamine reactions. We've done that in vivo, in vitro. We've tested it in all ways. They don't trigger a histamine response. And so, but that doesn't mean that we should just go out and give everybody spores, right? That's not what I'm saying. What we're saying is that there's in those patients, you really have to go slow. If you're going to introduce the spores and this idea of total gut restoration, you have to go very slow with them. The dosing with these types of patients, we start them at half or quarter of a capsule every 2 or 3 days. We just want to get something in so that there's something happening, and then we can see how they respond. With a lot of these patients, if you're not addressing the emotional component of their situation, you're really not helping them at all. And by stepping in and saying to them, look, I recognize the sensitivity, I recognize your situation, I don't want to trigger a reaction, so here's how we're going to treat you. That by itself is a very important emotional component for these patients, that you're recognizing the uniqueness of them and that you have a plan. And so with this, the things that we're not really saying that it's a different plan. It might be in a different sequence. It definitely will be at much smaller dosing to start, and then observe them and observe how they do. Observe what they're reacting to and what they're not reacting to. The hard part about those patients is I can't give you a cookbook. I can give you these tools, but I gotta say to you, go slow and figure out the dosing that works best for them, or the order that works best for them. And we talked about the Mega Mucosa, and it's a very effective product, but for some of those patients, the amino acids irritate their intestinal lining, and they express discomfort with Mega Mucosa, which makes no sense. It's supposed to be healing the gut lining, but it's too much. They're too raw. So in those cases, I usually start with IgG standalone, the Mega IgG. And I use that as a way of putting out the fire. For those of you that are in parts of the world that it's very hard to get bovine products, colostrum is another acceptable form of IgG. The problem with colostrum is it's inconsistent in the amount of IgG from dose to dose. There's some toxins associated with colostrum that aren't that we don't find in the serum. And so colostrum's not as good as the serum bovine IgG, but if you can't get the serum IgG, colostrum is your fallback. And in many parts of the world, that's what it has to be at this point. So.
Okay, so speaking of canaries in the coal mine, children and the use of a protocol such as this one, how do you aim for the dosage on the package, or where do you?
So here's what I say to everybody, okay? I have treated thousands of patients with these protocols. I have consulted with doctors who have then treated thousands more, okay? I really believe I've seen everything, but I can't tell you who is going to have a negative reaction to supplementation. I've seen people who look to me outwardly healthy, that we were just trying to improve their health, not necessarily treat a condition, and they've had an uncomfortable reaction to this protocol. And so what I do with everybody is I start slow. I use titration with the spores. I go half a cap every other day for a week. I go a cap every other day for a week. Then I go a cap a day for a week. Then I go 2 caps a day. And so if they have any reactions along the way, I back it down. The prebiotic, I'm not going to say the prebiotic, no one has a reaction to prebiotic. That's not true. It's a small percentage. And it's typically because there's some kind of bacterial overgrowth in their small intestine. And so, but for the most part, you don't have to titrate the prebiotic. I mean, if you put somebody on prebiotic, they immediately get bloated, then back it down and change the order of things that you're doing it. But the step 1 and step 3, I recommend everybody titrate, go slowly, increase it slowly across the board. When you talk about your canary in the coal mine, you're titrating from the titration schedule. You're going even lower than that. And so, so with kids, same way. We're in the process right now of developing a child's liquid and a child's gummy. It's about 30% less activity than the spores we use now. So we just lowered the CFU count a little bit and blended it, the certain strains in a way so that it's more tolerable for children. But we don't have that yet. So how do we treat a child today? We treat a child today exactly like we would treat the canary in the coal mine. We use the same protocol, we just titrate them slowly. I have given full adult dose to a 1-month-old, and they did fine. Their bowels were fine and everything was good. I have a 10-year-old patient now who can't tolerate more than 1 cap a day. If I give him more than 1 cap a day, he gets loose stool. Okay, I'm not interested in making this kid's life uncomfortable. I want to help him heal. We're not doing it by giving him more probiotics. We're creating stress. And so what I'm doing is I'm focused on the IgG, I'm focused on the Mega Mucosa, focused on the prebiotics, and we're just doing a little bit of the probiotics because I've through my process, I've seen that that's what gives this kid a loose stool. And we've been at it for 6 months and it still does it. And we back down for a month and then I try to go up again and it does it again. And so I haven't figured it out yet. And so I will. He's in a much better place. The symptoms that he came in with are gone. But the thing with the spores is until you get over 3 billion a day, you don't get immune modulating benefits. And this kid's got a dysfunctional immune system. So I need his immune system to accept the spores and heal itself, right? But I'm not getting that right now. I'm getting competitive exclusion. I'm getting nutrient production. I'm getting all those benefits of the spores, but I'm not getting immune modulation because that's a numbers game. And I've got him at about 1.5 billion a day right now for him not to get diarrhea. When I bump it up to 3, he gets diarrhea. So the point is, whether you're talking about your canaries in the coal mine, whether you're talking about a new patient, whether you're talking about a child, there is no cookbook. The cookbook is, these are steps 1, 2, and 3. Now you have to use your intelligence, your clinical acumen, and you have to use them and observe what's happening with the patients and walk through it with them. You can't walk away from your patients. You have to participate in this process with them.
Super. So can we also put it into smoothies?
Anything. So we've cooked the spores at 450 degrees for 20 minutes with 0 attrition. They're incredibly robust. And so you can put them in a smoothie, you can put them in sprinkle them on your food, your hot food, whatever you want to do. Doesn't matter. And they really don't have a taste either. So it's not going to impact the taste profile at all.
Excellent. So, Dr. Baynes, in regards to Akkermansia, there is some research that indicates that high Akkermansia is also a possibility, and high Akkermansia is related to irritable bowel syndrome. Do you have any comments to this? Because we are very much focused on feeding the Akkermansia, but when there's too much?
It was like I said, spores use quorum sensing to balance the environment. If they go in and Akkermansia is overgrown, they will kill off Akkermansia. They will reduce the numbers of Akkermansia because it's, again, like the H. pylori story. We want it to be balanced. We don't want it to be excessive. We don't want it to be absent. We want it to be balanced. And so if we get into a situation for whatever reason where the Akkermansia is overgrown, it doesn't equal inflammatory bowel disease or some condition. It equals dysfunction, and that dysfunction is going to express itself however that individual's dysfunctions are there, with their genetic makeup, their traumas, whatever it might be. So an excess of any bacteria is a problem. We need balance.
So some asked, and I'm just going to comment a little bit here because I'm actually a, certified FODMAP practitioner, educated in London at St. Thomas Hospital there. And with a good education to the patients, a low FODMAP diet works quite well. Yeah. But, and I haven't actually experienced with the FODMAP product yet for those patients who can't follow, because of course there are some patients who kind of gets depressed, or it's too hard, it's too stressful for them to follow a strict diet, and the low FODMAP diet is a strict diet. So but the question comes here, I don't know if you have any numbers. If a person only uses FODMAP, is there a reduction in symptoms? Has that study been done? Or
so what we've done is we had 3 clinics where I wouldn't call it a double-blind placebo study. It was more of a observational study. And so we put about 200 patients through these 2 clinics. And what we saw initially, we gave the product to patients who were on FODMAP diets, and they were following it. And what we saw out of those patients was a dramatic improvement in overall how they felt. So they were following the diet, they felt better. And we gave it to them first, like, okay, here, take this. And all of them, most of them, I won't say all of them, that's an exaggeration, but most of them came back and were like, my energy's better. I have more of clear thoughts. I'm thinking better. I feel like my old self, right? So these are the reports we were getting. And so then we start supplementing FODMAP throughout the journey. Like somebody's walking in and now I'm saying, you need a FODMAP diet and you need to follow that, but I'm going to give you this enzyme. You need to follow this diet, follow it the best you can, but take this enzyme with it. And we've seen great improvement with those people too. Now, I can't discern whether it was the diet or whether it was the enzymes. And so, but we saw really cool changes with existing patients. We saw really good changes with startup patients. And then we went back to the people who quit and said, I can't follow this diet. And we were like, please come back in. Let's try again. And we gave the supplement to those patients. Now, of the 3 things that I just pointed out, that group of people had the least amount of improvement because they were still eating terribly, right? But some of them, a significant percentage of them, saw improvement still, even though they were not eating correctly or not eating as they should be. So this is how we broke up this study, was in these 3 parts, right? And we saw dramatic changes in the first 2, but the second one, we don't know if that was just associated with diet or what. The third people, we thought, are we going to see anything? Sorry, my dog's barking.
We would like to see the dog.
She's downstairs. We're in construction. She hates people. Yeah. Anyway, so we did see changes in people who refused to change their diet. It wasn't as impressive as the people that would, but nonetheless, we still saw it. And so now we're doing a larger scale study that's kicking off in March. And so we'll have more information to give you then, but it's an enzyme product. Try it out. If it works, it works. If it doesn't, it doesn't, right? It's not, you don't need a second bottle of FODMAP if you don't know the first bottle worked, right? If you haven't seen change the first bottle, there's absolutely no reason to take the second.
Excellent. So I just want to just put attention to the fact that we did with Dr. Bayne, we did another webinar, which is about half a year ago, but it's in Nordic VMS under education, which is only focusing on spore probiotics. So if you want to dive a little bit deeper there, please go and visit that in VMS under education. You find all these webinars. You will find this webinar there as well. So I think I've tried to pull out all the comments and questions and for this.
Please put them in an email and send them to me. I will answer every question. I have no issue with that. It may take me a couple of days to get it done, but I have no issue. I would love for everybody to walk away from this having their questions answered. So I know we didn't get to everybody's questions. So if you put that in an email, I'll shoot it back to you in a couple of days with the answers, and and then you can disseminate it to the crowd.
Excellent. So you can send it to our info. Well, actually send it to our event, and we will put them all together in one email to you. And then we will share all the answers to you all, those who attended, but also those who didn't attend and watch the video. So we will try and share with as many as possible, because the aim with these webinars is for you to get help and support and learn, so that remember that we are better tomorrow, we are better next month, we are better next year. Remember, that is the aim. And it's so lovely to see you writing together and answering each other's questions. I loved the question about the canary in coma, how that was the canary in a coal mine. And see, that's a wonderful thing with different languages, that we hear things and we get a good laugh out of it. And I just love things like that coming from this very international bilingual family myself. So thank you everyone for your time, and all the thanks are popping in. I'm sure you can see them, Tom. So see you on the 17th of February for nucleotides information. Tom, Dr. Bayne, thank you very much for your sterling presentation. I have to say that was very well done, given the time we had to prepare, etc. for this. Thank you.
Thank you. I appreciate you and Chris. Any way we can support you guys, happy to do it. Thank you everybody for coming. Thank you for your time. Be well.
Bye.